Welcome everyone to our RxTalks webinar brought to you by Omeda Rx. We're happy to have you join us today. We have our resident speakers, Dr. Steve Lamb and Rich Adams, and today we have a special guest, Dr. David Robertson. My name is Allison Donahue and I'll be your moderator. I'll be keeping things running behind the scenes. I'll go over some housekeeping items, share the answer to our poll question, introduce our speakers, then pass it over to them to review our topic. At the end, we'll wrap up with a question and answers. Out of respect for our presenters, everyone is automatically muted. We will capture questions throughout the presentation using the dialog box. Simply submit your questions and we will send them to the presenters to read and answer later in the presentation. Today's session will be recorded. Now for the fun part. Several of you answered our poll question when you registered, and now it's time to reveal the answer. The question was, which types of drugs can receive rebates? And some of you got this one. It was brand drugs only. So thank you everyone for participating in that poll question, and look for more opportunities to engage in future webinars. Now I'd like to introduce our speakers. First off, Dr. David Robertson. Dr. David Robertson currently serves as the Director of Pharmacy Clinical Services for Omeda Rx, where he oversees formulary development and maintenance, utilization management programs, pharmacy and therapeutics committee, unit cost contracting, total cost of care programs, provider outreach, and medical and specialty pharmacy strategy. Prior to coming to Omeda Rx, David worked at other Oregon health plans overseeing clinical services, including drug review, formulary development, unit cost, and quality. David strives to provide innovative clinical services to improve the safety, effectiveness, and affordability of medication use in the communities we serve. Dr. Steve Lamb currently serves as a clinical pharmacist client manager for Omeda Rx, where he has strategic responsibility for developing, communicating, and reporting the outcomes of clinical initiatives impacting both cost and quality of care to members and clients. Prior to joining Omeda Rx, Dr. Lamb was the resident pharmacist at a large health plan in Oregon, where he was exposed to a variety of roles. His career goal is to create innovative and sustainable healthcare benefit solutions to promote the delivery of safe and cost-effective medications. Rich Adams currently serves as the Director of Business Development at Omeda Rx, where he oversees sales, account management, and product development. Before coming to Omeda Rx, Rich held various sales leadership positions at industry-leading healthcare companies. Rich's career work focuses on helping organizations navigate the new health economy. With that, I'm going to hand it off to Rich Adams. Rich, take it away.
Hey, thank you, Dana, very much. Dr. Robertson, welcome. Thank you for joining us, taking time today. Very excited to have you here and have your expertise here. And Dr. Lamb, welcome, welcome back. Thanks. Today we're talking about rebates. Lots and lots of news in the press, in the federal government and in state governments, across industry trade groups regarding rebates. And so we thought it would be a good idea to talk about rebates as a whole. What is their function? How do they operationalize? What are the different models that are out there? What's the relationship between rebates and evidence-based medicine? And then as we look out 12, 24 months, what can we expect to see in terms of rebates as they evolve in the marketplace? And excited to have Dr. Robertson here, who is an expert in this space overall. So here's our agenda. We're first going to talk about, create the context, the backstory of why this is so important right now. And we'll talk about the function and what the real goal of, one of the primary goals of rebates is in the industry. Then we'll talk about something called the value chain, as rebates move through the different key stakeholders in the healthcare value chain. Then we'll talk about the different contracting models that are out there, what we've seen since 1990 when OBRA first introduced the Medicaid rebate entity itself. Then we'll talk about developing an evidence-based medicine formulary and how do rebates fit into that. And Dr. Lamb will help walk through that. And then finally, we'll end with questions, as we always do, questions that folks on the phone, our participants can ask their PBM about rebates to help understand how the PBM that they're speaking with, how they view rebates and how they deploy them, and whether or not it's a good decision or not to work with that PBM based upon their rebate model. So here we go. So many of you on the phone and participants have seen this slide in the past. This is total U.S. prescription drug spend for historical actuals from 2006 with a forecast through 2022. And we've talked about in the past from 2006 to 2013, relatively calm waters, $200 billion to $262 billion in spending over time, incremental increases, but then suddenly in 2013, a very, very dramatic uptick in total spend. And that's really the entrance of specialty medicines into the marketplace within the US, and that was hepatitis C. We all have talked at length about Vicarapac, Harvoni, and Sovaldi, and the number of patients within the US that are taking those medicines and the impact that it has had on cost. And we've also talked about other drivers of cost, whether it be the increase in FDA approvals, the intensity of marketing efforts, other specialty drugs, and then the types of drugs that are in the pipeline itself, whether they be drugs on the medical benefit or drugs on the pharmacy benefit. So lots and lots of drivers that are really moving this cost curve up at a 6.9% annual growth rate. It's important for us as professionals in the healthcare space, as employers or agents or consultants or other folks that participate in the health insurance space, to really tackle this problem, because it's one of our employers and employees' most pressing costs. And so we need to figure out and come together and evaluate and decide on strategies to really manage these more effectively. And understanding rebates is critical to that. So as we look at, as we start to break down that cost curve, we want to parse out something called brand drugs. And as we enter into this discussion, my first question for Dr. Robertson is, tell us a little bit about the different classifications of drugs out there, whether they be brand or generic, and then also the classes of trade. And why is this important to the rebate discussion?
Great, thanks, Rich. I think those are really important questions, and we need to level set and make sure we're using terminology, because it can be very confusing in terms of making sure we're talking off of the same script, so to speak. So if we ask about brand drugs, well, how do you define a brand drug? A brand drug really is defined as a drug that's under patent protection or some type of exclusivity that's given under the FDA approval. So patents can be given anywhere along the drug development pipeline and are issued for around 20 years once they're granted. So, and then on top of that, the FDA may provide some exclusivity. The bottom line is these drugs are not going to have competition that will drive price down. And so that opens up the opportunity for us to negotiate rebates with the manufacturers where there's competition that exists. A generic drug, as most have heard, is really that copy once a patent or exclusivity arrangement is no longer valid. And so that allows and opens a door for generic manufacturers to come and provide a exact copy onto the market. That will drive competition and prices down over time. Another concept that's important is to think about is single source versus multi-source. So single source is when a single manufacturer, single source is available for a product. Typically, your brands that are protected under patents and exclusivities are single source. There is not the competition to drive that price down. Multi-source is when that competition comes into play and we can have multiple sources, multiple manufacturers. And last, you mentioned class of trade, and that's a concept that's really defined by contracts. But essentially what we're thinking about is drugs and how they flow through the distribution channel, whether they be retail, mail order, specialty, hospital, clinic. And under those contract agreements, different discounts and rebates will apply differently depending on how they flow through the market.
Got it, that's great. And then so for this particular conversation, as we heard from Allison earlier, we are only talking about brand drugs. And those are the only drugs that qualify for a rebate.
Yeah, largely that's true. There is a movement or some change where some high-cost generics are now entering the market, and they are single source, only one manufacturer. Some have heard of Valiant and some of these other manufacturers that drive prices up in a substantial way. Those don't have competition. We're starting to see rebates enter that marketplace. But by and large, we're talking about brand drugs only.
Okay, got it. That's great. And as we kind of close out this slide and move on to the next slide, where we're going to talk about the different economic mechanisms that pharmaceutical manufacturers can use to access patients, we want to point out that as part of that larger cost curve that we saw earlier, we can see here in this slide that brand drugs are playing a critical role in that cost increase. And you can see in 2006, this slide depicts basically compared to CPI, the increase in prices for a top set of drugs running about 5.9% back in 2006, and all the way fast forward to 2015, you're up about 15.5%. More recently, you're seeing a 12 to 14% year-over-year increase, but that's a pretty dramatic and critical element to this management of our cost curve.
Absolutely.
So as we look at drug manufacturers through the lens of commercial interests, we could say that their primary interest is to get access to a patient with their product for the purposes of driving volume, gathering market share, reaching a positive return on investment for their investors, so on and so forth. And there are a number of different tools and mechanisms that are available to pharmaceutical manufacturers to do that. Rebates is one of them, but there are others. So Dr. Robertson, can you walk us through each of the different elements or components and tools that pharmaceutical manufacturers use to gain access to patients?
Absolutely, and there are a lot of levers that they use. And so, the first one is really around media. So beginning in 1999, even before that, the FDA relaxed their rules on direct-to-consumer advertising. And so this has led to the advent, I think all of us have seen the commercials, the butterflies, the purple pills, and those types of things that really try to promote a specific product. And where's the money behind these? The money is in the branded products. And so that does influence prescribing behavior. On one side, the manufacturers would argue that it's about empowering the patient and the consumer to know that there's treatments available. On the flip side, others would argue that that's really influencing a much higher net cost product because advertising works. We all know it works. And so that's a huge driver today. And really, it's the number one exposure to health-related media is drug manufacturers now today in our communities. Patent law, I touched a little bit on that earlier about how patents are used to protect medications. Really, when these patents are issued, it requires the courts to determine long-term if they're valid or not, and when can generic entrants come into play. And so there's a lot of work into pipelines, generic pipelines, and trying to understand when can these generic manufacturers help to drive down price when the patents no longer become valid. And there's efforts now underway, and others may have heard, where there's something called pay to delay. And what that is the brand manufacturers paying generic manufacturers to prevent them from bringing a generic copy onto the market. So a lot of strategies here to really gain and control market share over time. Detailing speaks to what really was the historical way that manufacturers promoted and influenced prescribing was directly to the providers themselves. And so on one hand, they're providing important information within the labeling requirements that help providers prescribe medication safely and effectively. Similar to media buying, there's a similar bias in terms of the money behind that marketing, again, is behind the branded manufacturers, perhaps at the expense of lower, equally safe, effective, and more affordable opportunities. Rebates, I know, is kind of the heart of the conversation today, and we'll talk about deeper around what some of the drivers here are, but ultimately it's about purchasing access to patients. And through those financial incentives, getting preferential placement, whether it be under benefit designs, formularies, and other access strategies. And lastly, something that's really taken on a hold lately are couponing strategies. And what this is manufacturers providing an offset to the patient out-of-pocket costs, which is a good story in a lot of ways. However, it's also used to circumvent some of those controls that others put in place to influence the lower net cost option being used first. So coupons, definitely an opportunity for patients, at the same time posing a challenge to the overall cost of the system.
That's interesting. Is it safe to say, a follow-up question for you, Dr. Robertson, is it safe to say that as a pharmaceutical manufacturer looks at the patient population in the U.S., they have basically an economic budget that they are going to deploy across all of these different levers, depending upon what type of market share they'd like to gain? And they would basically fund efforts on media, fund efforts on detailing, fund efforts on rebates and coupons, for example, to achieve a certain share.
Absolutely, and that's a huge part of their budget is really designed to getting the market share that they desire. So absolutely, and it is largely a fixed budget. There are certain controls such as Medicaid best pricing and other strategies that they really can't go below that. So there is a certain bucket of money really that's earmarked to gain this access.
Yeah, and it certainly begs the question of, well, what sits between these different levers and the patient? And I know it's a little bit of foreshadowing, but our clinicians here will say evidence-based medicine is absolutely critical, and we'll talk about that in a few minutes. So stepping back for a second, if we know that there is a very large expenditure of dollars within the United States on medicine, $31 billion, up to $425 billion, depending upon who you talk to for 2016 or 2017. It's interesting to look at what is the distribution of that expense across the different players in that value chain or in that supply chain. And I'm hopeful that you can talk a little bit, Dr. Robertson, about who the players are in the supply chain and the value chain, and then what is the distribution of expense or revenue across each of those players.
Yeah, you bet. I think this pie chart provides that that visual picture of what we're talking about. So if we look across the expenditures of drugs and you see what goes to brand manufacturers and generic manufacturers and so forth, about 20% on the right side of that pie chart is really earmarked for those rebates. So it's a tremendous amount of expense that's designed to buy that access ultimately. So on one hand, rebates are very important to offset the total cost and the total drive toward the total trend upward. And so it's something that's important, and it helps us leverage brand manufacturers where there might not be as much generic competition to help to lower the prices of the medication and help us bend that cost curve. On the flip side, some might argue, well, should we carve out that 20%, lower the overall net price of drugs, and really decide based on safety and efficacy and overall cost considerations. And so it's a bit of a push and pull, and we have to find the right dynamic and right balance. But absolutely, the expenses are tremendous within the market, and the opportunity to offset some of the cost as well. So rebates are definitely something that we need to ensure that we're leveraging appropriately.
When we see on the slide, just clarifying question for you, Dr. Robertson, when we see the supply chain entities here, are we talking about a retail store? Are we talking about a PBM, a carrier? Are we talking about the wholesale distributors of product? What do we mean when we talk about the supply chain?
Yeah, primarily we're talking about wholesalers, to some extent the pharmacies and others, but it's how the drugs flow through our system. So I think we're going to talk a lot about the sort of payer outpatient pharmacy perspective here today, but there's an analogous process happening on the delivery system side through the wholesalers, through the clinics, hospitals, and others that are taking bits and pieces of this pie.
So it's a component of, so we've got the manufacturer, which goes to the wholesaler, which goes to the PBM or the carrier, which then to the employer, and then eventually to.
Correct. Yep, good characterization.
And that's a good lead into talking about rebates from a functional perspective. So if we look at it at a macro level, how would we describe the flow or the use? What's the use value of a rebate as we look at it from a manufacturer's perspective, which we've talked about, hey, access to patient, but what happens, what does a PBM do with it? And how does it functionalize itself there? And then payers. Let's walk through that.
That's great. I think that's a critical element of understanding this. And as decision makers within healthcare systems and payers and other settings, employers and so forth, understanding this flow and this chain is really critical, and understanding which pieces you have influence and control over and how the models are set to drive the dollars basically through this supply chain or this chain, value chain. So, essentially what we have throughout it is agreements and contracts and so forth between these entities that you can follow essentially the money through. So as we discussed, manufacturer is really looking for that patient access. They want preferential access on formularies, under benefit designs, under policy and other strategies that are used to influence prescribing. And so they will contract directly, typically with a PBM, make direct contract with a payer as well. But ultimately, they are looking to get access to their formularies, get access to their UM policies. A PBM, in turn, typically takes a percentage of those dollars that flow through, and that is funding their profit, their bottom line. It's part of their revenue source. So there is a bit of a perverse incentive here in that both a manufacturer and a PBM make money as drug prices increase. So it's a percentage-based agreement. And so we do need that counterbalance, which if we flow through the rest of the slide, you start to see the payer come into play here. And so a payer then will contract with a PBM, and they will have those rebates and other fees passed through to them in some form or another. And we'll talk about models a little deeper of what those kind of look like. But ultimately, what the payer's incentive here is to try to offset their premium, try to have a lower cost option so that they can fund their services, and typically may take a portion of that as well. And then on to the ultimate purchasers, employer groups, government payers, what have you, and they use those dollars to get access to the premiums, lower premiums. In some cases, those dollars may make the difference to even be able to provide benefits to their employees. So these dollars then help to hopefully overall lower the cost of care. As you can see with the schematic, it's complex, and all of this leads to lack of transparency. So it's critical to understand where your organization, your perspective fits into this, and try to follow those dollars through that chain.
That's a really good description of it. Clarifying question for you, there's a piece that's missing here, and it's the patient. How does that fit in? And then a second follow-on question to that is there a sense of timing about how this flow works? Is it instantaneous, or does it protract over time? And
yeah, really good question. And perhaps it is an indictment of this model. Where's the patient? It's, right? The patient should be at the center of this, not on the side or heavens to be left out completely. And so I think that's a critical question. And it's harder to draw the direct line connection between the manufacturer and the patient. Ultimately, the argument would be that they're getting access to healthcare if it's able to keep the benefits. Hopefully, their lower premiums, out-of-pocket costs are lowered. But the timeline you mentioned is critical here. It can take 18 months or longer to get from the manufacturer to the ultimate end user. And so there's an inherent delay there, which further causes issues with transparency, with really trying to connect those dots. So ultimately, we're hoping that this offsets, the rebates flow through and ultimately offset some of those patient out-of-pocket costs.
And the delay, the almost 18 months, what drives that?
It's really, from when the claim is processed at the pharmacy. So the claim process that's the point in which the drug is being dispensed to the patient. So that then going back requires that to be invoiced to the manufacturer. So there's reporting analytics that need to occur to show that actually happened. It goes into the payer databases, which then get fed back to the PBMs, who then ultimately invoice or sending essentially the bill to the manufacturer, who then needs to validate that all the pieces were in place, the contractual terms were met, finally issue the check, and then go through the financial reconciliation and back ultimately to the end user and purchaser. So that process today just takes that 18 months essentially to flow through that channel.
I can see why you call it complicated and not transparent.
Absolutely.
Let's take a look at it from a contractual view now. And so since 1990, when OBRA first introduced the rebate component, introduced rebates on the Medicaid side, we've seen a variety of models out there. And there is, from my perspective, there's an ebb and a flow to these. And a lot of it depends upon how much investment pharmaceutical manufacturers are interested in putting towards rebate as a whole in the marketplace. So if it's smaller, it tends to be one model. If it's larger, it tends to be a different model. Can you walk us through, Dr. Robertson, a few different models, what you typically see in the marketplace, some of their features and some of their benefits, and maybe even some of the risks?
Absolutely. And you're right, there is an ebb and flow to this. So I think as the different economic models, some of the market dynamics of the products are in the market, not in the market, that causes an ebb and flow. And so I think that there always is some shifting around of the different models. But we think fundamentally, what models are we talking about? Fixed dollar is a very common model. So in that sense, whether it be between the PBM and the payer or the payer and the employer, it is passing along a certain amount of money that will go through to the end user. And so this provides some level of budgetary certainty, particularly when we're talking about guarantees, and I think that's the next concept to bring in. where guarantees essentially is you're going to get a fixed dollar amount regardless of how the PBM or the payer performs. That's what really provides some budget stability, and if there's underperformance, the organization at risk is at risk for those dollars. However, if it's just a flat guarantee, then you're not necessarily sharing in overperformance, performance above that guarantee. Some will share a percentage of that performance above. So essentially what you've got is a mix of guarantee or no guarantee, and then a fixed amount or a shared amount depending on the performance of the actual rebates.
When we think about this from a sense of timing, we talked about 18 months perhaps as when the rebates actually work their way all the way through the system and then apply to the employer. Is there a difference in model from payout to the employer from a fixed dollar versus a percentage based upon that timing?
Yeah, so with a fixed dollar amount, you're generally looking at 30-day arrears, so you're looking at shortening that time frame. The guarantee is also shortening that time frame because the guarantee is a guarantee. Anything above that, if you're looking at performance-based, will take more time to get back and flow through to the end user.
Got it. So if I'm an organization that is interested in cash flow and managing my cash flow very, very tightly and discreetly, I would be more inclined to look at a fixed dollar, I would imagine.
Correct.
If I'm an organization that's not necessarily concerned with cash flow, I might have the liberty to take a look at a percentage share.
Absolutely.
That might be one way of thinking about it.
Absolutely.
Okay.
Great summary.
Thanks. Let's talk a little bit now about elements of a good rebate contract. This would be an operational view. So as PBMs contract with employers or carriers contract with employers around rebates, there's got to be some good best practices, fundamentals in terms of contracting that come into play.
Yeah, you bet. I think there are definitely some things to think about as one would enter into a rebate contract. You know, firstly, we want them simple. We want them to be able to be understood. We want them to be predictable. And there's a variety of different strategies in place, whether it be a fixed percentage, a percent based on a performance of a particular market share-based performance. There are things such as price protection, which prevents or shields the organization from price increases over time. Sometimes those can get very complex. So we want to avoid things like bundling typically, where there are multiple drugs that have to be available to get the contract. We're better off being very simple, streamlined, predictable. Fees for administration, we've sort of alluded to this, but there are two elements of most rebate contracts. There's the there's the base rebate, which essentially is typically a percentage based on the wholesale acquisition cost, that if you meet the terms of the contract, let's say you get 10% of the cost of that list price back. But there's also administrative fees, and these are fees that are paid by the manufacturer to whoever's administering the contract to do that, to do the invoicing, some of the reporting. So it really pays them to manage the contract. Those can be passed along in those models we just discussed in various ways, percentages in total or none at all. So you have to understand the agreement that's in place. So make sure you have those administrative fees as part of the agreement. We also want it to be flexible to changes in market dynamics. As we all know, healthcare is changing constantly. And some contracts have been long-term, 3 to 5 years. Other contracts last a year or less, or some move with as the market moves. So I think more and more the flexibility is important as things like generics, new competition, other things can come in and change on what feels like almost a daily basis. And then standard reporting. You want to make sure the analytics that you're doing, you've agreed to what you're looking at, you're able to track it and see that it's consistent and is manageable over time.
You have a follow-up question for you. You mentioned price protection. Can you talk a little bit more about what that mechanism is and why is it in play now and why is it so important?
Right. So, one of the slides we showed earlier was a bar graph that showed that price increases over time are up in the 15, 18% sometimes year over year. And so what a price protection agreement does basically is says in one of two ways, either it anchors the price to a specific fixed period of time, or it resets on an annual basis. But in simple terms, what happens is if the manufacturer raises a price by 10%, and you have a fixed price that says you cannot raise above 3%, then you get that 7% back in additional rebates. And so what that does is it shields the organization from those price increases that have happened year over year for multiple years now.
Oh, I get it. So you could strike a great rebate deal, but a manufacturer and entity could go and increase the price dramatically, which would offset the great rebate deal.
You got it.
And so it puts some kind of some bumpers and some boundaries around that type of action.
Yep, it protects the organization from those constant increases.
So let's switch now and let's talk a little bit about evidence-based medicine, developing a formulary. We've talked at length about the energy, the investment, and the effort that's being put forth to grab market share through patient access, the different rebate models, the timing of it, the function of it, how the different components of the value chain use a rebate. But let's talk about how do we really, from a quality standpoint and a safety standpoint, how do we put all this together so that we're keeping the patient's best interest at the forefront? And to that, we'll turn to Dr. Lamb to talk to us about developing a formulary.
Yeah, sure. No, that's a really good segue into evidence-based medicine and how we kind of leverage rebates, but certainly the evidence as well to develop our formularies. So, Rich, as you know, some of our audience members who have joined us for previous RxTalks will remember that there's a lot of different philosophies that PBMs can take in how they manage or develop formularies. And these different approaches will give a very different experience for the groups and for the members. So for health plans, PBMs, and even the FDA, if we look at the primary point up there, safety is always going to come first. It's the first thing that we consider, that we evaluate, because if a drug isn't safe, it isn't likely that we're going to use the medication. But that kind of opens up to an interesting discussion in that secondary and third bullet point down there for rebates and value, because there's a lot of different things that we can do there. So philosophically, certain PBMs can take one of two routes, right? So after we evaluate the medication safety and the effectiveness, we can look at either A, the positive outcomes for the patient, or do we look at the economics? Do we look at the value and the rebates that are associated with the medication? So for us at Regents, what we put our focus in is really to evaluate the medication safety and effectiveness first, but then move on over to the outcomes prior to looking at the value of a medication. Value really comes in last, because we really want to ensure that the drugs that we are using are safe and effective and produces positive health outcomes. And when we think about health outcomes, what we really mean is it clinically meaningful? Meaning, does it improve survival? Does it reduce heart attacks? And does it reduce stroke? Because long term, we know that if we are able to prevent these effects, then we're actually going to save more net of net. So those are really important things for us. Other PBMs might take a lot of a different approach, where they evaluate the rebate or the value prior to looking at the outcomes of the patients. So if we want to take an example of this, I think you alluded to earlier in the talk that Vicuripac was very expensive when it first hit the market back around 2014. But I think it also paints a really good story about how different philosophies really produce a different formulary for different PBMs. So when it did gain approval back in 2014, it entered a very hyper-competitive hepatitis C market. We had two drugs that were basically dominating at the time, which included Sovaldi and Harvoni. And so as any good drug manufacturer would do, they would leverage some of those tools that Dr. Robertson has mentioned before to really try to gain patient access and market access, and to try to gain preference on a formulary. So one thing that AbbVie, who was a manufacturer for Vicuripac, actually did was they offered significant discounts to the market and to certain PBMs. And for a large part, this worked really well for them. They were actually able to gain preference on a lot of different PBM formularies, and got some pretty good market share. But for us at Regents, as we've talked before, we really look at the safety, the effectiveness, and then the outcomes first before we evaluate the value of a medication. So when we dug deep, when our clinical pharmacists looked at the evidence and the safety of the med, we actually saw that there were some inconsistencies in the safety profile of the medication. And so what we did was we said, despite there's a significant value associated with this medication for Vicuripac, we're not going to prefer it because we're not sure how safe this medication really is. And we really want to protect our consumers. That's their best interest first. So what we later learned was that, our decision was right, because the FDA came out with a warning that basically said that Vicuripac produced some sort of severe liver injury for a lot of patients out there. So a lot of those PBMs and who decided to prefer Vicuripac on their formulary was in a lot of hot water because they went with the value proposition first, looked at the economics first, prior to actually critically evaluating the evidence of the medication. So
that's a great example. I hear from you that there is a bright and shining line. There is patient safety first, then medical necessity and positive outcomes, and then the bright and shining line, and then it's rebate. And that's absolutely critical. And I think from our earlier conversation, that's the that's the insertion point where a high quality PBM or a carrier inserts themselves between the different economic levers that a manufacturer has at their disposal to gain access to a patient and the patient themselves. Evidence-based medicine.
absolutely.
Okay, thank you for that, Dr. Lamb. So stepping back, looking towards the future, Dr. Robertson, as you look into the horizon and are talking with manufacturers and seeing the marketplace evolve, what can we anticipate happening over the next 24 months in terms of rebate models or different trajectories that manufacturers and perhaps PBMs and health plans are taking to manage rebates?
Yeah, I think there's a few areas that are evolving and different organizations are starting to dip their toes into. One is a concept of indication-specific rebates. And so this really plays to the idea that there are some medication classes where there are drugs that have multiple indications, and one could contract rather than on the class and sort of all or nothing situation, be able to contract for a specific medication for a specific indication. So a great example of this is in the drug class we call anti-inflammatories, chronic anti-inflammatories. These are drugs that are #1 on essentially every health plan's list. That are used to treat rheumatoid arthritis, certain inflammatory bowel disease conditions, and psoriasis. And so most traditional rebate agreements have an all or nothing, where you have to have 1 to 2 products to treat all of those conditions, and it's all or nothing. As that market has evolved, we've had new medications in the same class that might have different characteristics. They might be taken orally instead of injectable. They might have some better evidence for the overall outcomes. So rather than using an all or nothing approach, we can get potentially some additional value as well as provide providers with additional choices if we do it on an indication-based approach. So you might have 1 to 2 drugs that treat psoriasis and maybe 2 different drugs available preferentially to treat rheumatoid arthritis. That allows some additional value by actually taking that competition into a more granular level where manufacturers are competing for additional competition for the manufacturer. So this notion of indication-based or specific rebates may provide us an avenue for some additional value and even allowing us some additional choice as well.
And for a layperson, when we talk about indication, that sounds like condition-specific.
Correct. The reason we use the medication.
Got it.
So the reason they're taking it.
So just not by therapeutic class.
Correct.
The actual reason. So more precise.
More precise, and allows that competition to occur at a more precise level. So it's more opportunity for the manufacturers to compete.
Great.
Another concept that's out there is value-based rebates. And this you see different terms, outcomes-based rebates, performance-based rebates, but the concept is the same. And that is when a medication is brought to market, in order to be approved by the FDA, they have to demonstrate it works in clinical trials. And so that's typically a very controlled environment. So let's say we're using a medication to reduce heart attacks or strokes. And so in a very confined environment of a study, it is shown to be effective. When it gets out into the quote real world where it's used in actual practice, those outcomes, the way it works may not actually translate in reality. And so the idea is to say to the manufacturers, if we've got a new drug to treat heart attack and stroke, we have other drugs to treat that same condition, the same reason they're using them. But these new drugs will come in at a premium. They're single source, branded, specialty often products that command a higher price. So the concept is really manufacturer demonstrate it works. Demonstrate that what you saw in the studies, which ideally is a reduced negative outcome, so we stop heart attacks, we stop strokes. If you don't demonstrate that that actually occurred and we paid more money in for these drugs, those need to be paid back to us in additional rebates. So it's a way of putting the manufacturer at risk that the outcomes that they are touting out in the market actually happen. So while this sounds great and it puts the manufacturer at some risk to demonstrate it works, it also has some drawbacks. And the drawbacks are we talked about a fixed bucket of money that's used to do rebates, to do all the marketing and so forth. So are they just taking money that would have otherwise been to gain access and just putting that at risk? And therefore, the manufacturer actually may end up paying less if indeed the risk money didn't come to fruition. The other risk is it takes a lot. It's a lot of heavy lifting. Analytics, coming to agreement that what we're measuring is accurate and true. All of that takes a tremendous amount of work. So we're starting to see some big payers press releases that they're doing this. I think we're dipping our toes into this water. Not a lot of dollars today behind this, but perhaps this is an avenue towards really outcomes-based care, value-based care, which in theory makes a lot of sense.
Between indication-specific and value-based, I hear you saying, I think indication-specific has a little bit more value right now as opposed to the value-based rebates. And you're cautiously optimistic on the value-based, but not too hopeful. That's what
correct.
Kind of
I think that's a great summary. And again, I think value-based ultimately aligns well with a lot of what we're trying to do in healthcare about promoting outcomes, but it's a lot of heavy lifting to get there. Indication-specific is more of a twist on our current model to gain further leverage. And I think the last one that's worth noting is we talked a bit about the patient. Where's the patient in all this? How do they benefit from these agreements? We talked about the 18-month delay between when the claim processes, when the patient or member gets the drug, to when the rebates are actually paid. And so the idea here is to try to speed up that process and allow the rebates to flow through quicker, or perhaps the carrier basically holds that money and wait for it to be pulled in. So in other words, and this is typically in situations where you have high deductible health plans, high co-insurance, that the patient is driven to a higher list price where the net price to the payer is actually lower. And so the member oftentimes ends up paying more out of pocket than less. So let's get that rebate passed through quicker, get it to the point of service, get the patient to be able to benefit directly from those rebates and not more of the indirect we've talked about.
That's great. That's great. Well, what a good discussion. We started out talking about the dramatic and undeniable change in our cost profile, expense profile for drugs in the U.S. We've talked about the types of drugs that are classifications of drugs that are out there, whether they be brand or generic, multi-source brands, classes of trade, so on and so forth. We've talked about rebates as a tool among many that pharmaceutical manufacturers have to gain access to patients. We've then talked about a functional overview of rebates. How do they work in the value chain? We've talked about how different entities use them and deploy them. We've talked about contractual models, and then we've talked about evidence-based medicine. And then finally, we've talked about the future of. As we always do, we turn to Dr. Lamb and ask Dr. Lamb to walk us through a number of questions that participants on the call here can ask their PBM about how they address certain topics that we're talking about. And so today, Dr. Lamb, what are the 3 questions that you would encourage our audience to ask of their PBM to understand in more detail how they view rebates, how they use rebates to evaluate their formularies, and what are some critical elements that must be in place?
Yeah, thanks, Rich. And yeah, we've covered a lot of great topics today, but it really boils down to what are those 3 key questions, and we identified 3. So the first one that we have here is how do we provide examples of how rebates factor into the formulary development and management process? So as we've kind of discussed with the whole ViCuraPEG issue, it is, certain plans or PBMs will go with more of a value-based format first rather than following the evidence. And in most situations, that isn't necessarily the best way to go about it, because we always want to look at the safety of the medication, the effectiveness, and what are the deliverables as far as outcomes go. The second question that we have is provide examples of your organization's clinical practices that provide a checks and balances protecting the patient and the employer's drug spend. So why is that important? Clinical practices play a pivotal role in helping patients get the best medicine at the best prices with the best outcomes. Now, it's important to remember that, if we go with just a purely value-based model, we're going to ignore the evidence, which is not what we want, but we also want to balance that out against the evidence. So if you only purely follow the evidence, then you're going to miss out on some of that value piece. So you're not going to be able to derive or drive the best prices available for certain medications. So the last question that we have down here to ask your PBM is provide examples of rebate reports your organization provides to support the contractual agreement. What we really want to see is clear and consistent rebate reporting because it's really critical to evaluating the total net cost as well as maintaining drug management strategies. So we've talked about the timeline. It takes about 18 months for us to actually get a report about the actual rebates that are factored in. So how do we kind of compare that and contrast that against the total plan paid to get an actual net cost? How much are we actually paying for medication? So 3 critical questions that we need to ask for our PBMs when evaluating rebates.
Well, thank you, Dr. Lamb, and thank you, Dr. Robertson. At this point, I'm going to hand it back to Allison for a few minutes while our audience develops questions.
Yes, just as Rich said, this is the time to go ahead and submit questions. And speakers, you can take a drink of water. Thank you for the information. If we run out of any time for the questions, we'll do a follow-up at the end. Okay, looks like we have some questions.
Great, Dr. Robertson, I'll give the first question to you. I'll read it out loud. You mentioned that a fixed dollar rebate has a quicker time frame for reimbursement than a percentage share. Can you give us an idea of what the difference in time frame can be? Also, is there a difference in reimbursement amount in the case you're getting reimbursed? In terms of, I think what the question means is, does the reimbursement amount increase or decrease depending upon a percentage share or a fixed dollar?
Yeah, so that's a great question. So from a time frame perspective, going with a fixed dollar amount is typically going to shorten that window from 18 months down to even as quick as 30 days, depending on the agreement. So it can definitely shorten that timeline in a dramatic way. As far as differences in price, what's the value? Certainly, that's going to depend on a lot of factors in terms of how the pricing ultimately ends up. A guarantee versus a fixed dollar versus something at risk is going to be a negotiation really between the organizations to try to determine which is best. So ultimately, it's hard to say one is going to be less expensive than the other. Certainly, there's going to be a premium for certainty. So to the degree that guarantees are in there, to the degree that there's a fixed amount that will come across, there's a premium for that stability.
Yeah, I would imagine that there's a little bit of a risk premium that's included in that just because of the time frame that expires. So if you're looking at a fixed dollar, that's going to be paying every 30 days, I would imagine. And so what happens if that amount doesn't come to fruition? Exactly. The carrier or the PBM doesn't realize that for 18 months. So there's a little bit of a risk premium in there. Correct. Okay, great. Here's a second question. Question from the audience is, I'm new to the topic of rebate. Who determines the rebate structure? Is it the manufacturer? Are they similar to coupons?
Yeah, so typically it is the manufacturer. Now it's going to be a negotiation between the manufacturer and the payer, and so it depends on a lot of factors. What's the drug? How much? What's the nature of the medication? How much competition is there? How many market entrants are there for which you are negotiating between? So there's several different models, but typically what you're looking at is a fixed percentage to just gain that access. And then there's sometimes additional percentages that are added on top of that for market share targets and other performance metrics. So largely it's set by the manufacturer, but there's a lot of levers that the negotiators, whether it be a PBM or a payer, have to help drive what that structure of that agreement looks like.
All right, one more question, and I'm going to take on this one. And I'm very guilty of this because it's asking for a definition of what a PBM is. So PBM stands for a pharmacy benefits management company or organization. A payer is typically the entity that actually is paying the claims, and that could be an employer who has self-funded themselves and they pay the claims, or it could be a carrier who has taken on the risk or a health plan. So apologies for using the industry lingo and not actually articulating the full name of the abbreviations. But anyway, that's all our questions. What a really great webinar. I appreciate both of you guys taking the time to talk through a complex topic.
All right, yes, as Rich has said, thank you everyone for listening in. Please look for our next webinar in June, Emerging Trends in Pharmacy Benefit Designs. We will send a follow-up message to everyone on the call that will include a link to today's presentation and recording. There will also be a survey that pops up when I end the call. If you have time, please feel free to fill that out. Again, thank you for attending and have a great day.